Hi everyone, it's your friend Doris the Coder back with another video, and in today's video we are going to talk about time. Specifically, we're going to talk about time as a contributing factor and method for coding E&M services. This will apply to physician and non-physician practitioners only for those components, those services that have an option to code based on the key components, history, exam, medical decision making, or time, with the exception of the last definition. So we're going to talk about three definitions in this video. Number one, unit and floor time. Number two, face-to-face time. And number three, time on day. So before we get into that, I want to make sure you understand some definitions and terminology that I'm going to use throughout the video so you can see where everything goes. First, we hear about when we code based on time that the provider might spend, for two of these services, the first two, they may spend time counseling and or coordinating care. So what is counseling? What is coordinating care? Counseling and coordination of care, break those down. Counseling deals with the provider having a dialogue with the patient about what the diagnosis or diagnostic plans are, the risks, the management options, providing instructions regarding all of those. That is counseling. So usually there's a two-way dialogue, and this was created for those times when the providers were doing more work than what the code initially kind of required. So you might have a lower level service when you deal with the key components, but it's a patient that you've told, hey, you're a surgical candidate, right? Or there's a cancer diagnosis, or there's a particular kind of condition or treatment that the patient has, and this is how we're going to treat it, and this is what you're going to expect. Based on who the patient is, you may spend a great deal of time dialoguing with that patient about all of those things, and that's time very timely, right? So it was developed to allow the provider to be reimbursed for those kind of events. Coordinating care normally doesn't take place between the provider and the patient, but the provider and others. So it might be the provider and dealing with other providers. Like maybe we are discussing the results of diagnostic tests. We are putting in orders for diagnostic tests. We are putting in orders for consultations. We're facilitating next steps for the patient. So that might be home care or nursing facility care or physical therapy in the form of orders. We could be reviewing medical data, old records, diagnostic tests that have not come in yet, diagnostic tests that have come in since our last encounter, putting in those kind of orders. All of those things fall into the coordinating of care aspect. It may even mean speaking with caregivers, other caregivers that would be taking care of the patient, or in my case where I work in pediatrics, we're often dealing with the family. So that could also count as counseling when it's the family and the decision makers, surrogate or otherwise, that would make decisions on behalf of the patient. So the reason these definitions are important is because when we deal with the first two, you'll see in the guideline that when greater than 50% dominates, greater than 50% of the encounter time is counseling and or coordinating care, you can disregard the elements of history, exam, and MDM and code instead based on the time aspect of it. It's important to note that that's only applicable if that's just not what you have to code. For example, ED doesn't have a time metric included in it, and time-based critical care services are only coded based on time. So we would not use this rule or that guideline for those kinds of services. Throughout the book, though, you'll see several services, home visits, inpatient hospital care, nursing home care, rest home, like all over the book that apply that logic, and that's what that's applicable to. So now that we're clear on the definition of counseling and coordinating care, we'll get into the time definitions. First definition is unit or floor time. Unit and floor time is a definition that you'll find applicable to facility settings, okay, excluding the ones I spoke of before. So the code sets that are in those settings. For example, if you use the CPT code 99218 to 99236, that would cover your observation, which is in the facility, but it's outpatient type of service, as well as inpatient hospital services. So 99218 to 236 cover both of those settings, okay? Unit and floor time applies there because when we think about the time that the provider spends face to face, because they do, there's always time they spend face to face with the patient, the bulk of the service that's rendered to the patient that day is not done in front of the patient. It might be done at the nursing station or whatever space the provider has where they can review the records, talk with the nursing staff, speak with other providers regarding that patient, speak with case management to coordinate that level of care. A lot of that work happens not in front of the patient. So in the facility setting for those types, they'll say it includes face-to-face time as well as unit or floor time. That's time the provider spends pertaining to that patient on the unit or floor for that patient. The second definition we see is face-to-face. Now, when you're in settings like outpatient consultation, CPT codes 99241 to 245, that's where you'll see the face-to-face definition come in, right? Because, and this was the case before they made the new codes for office visits, it still holds true that most of the time, if you're counseling, that's where we often see it, counseling, coordinating care, most of the time spent in those kind of settings is in front of the patient. It's face to face with the patient. So when they wrote those codes, that was kind of the intention based on what they saw, the amount of work and tasks that were involved for the level of service. So if you are a provider that's even doing home visits, I don't know who's doing that now, because there was some relaxation in the rules where it no longer had to have this medical need for you to render the service in the patient's home. They relaxed that a couple years ago, I think, where you could just do a home visit, right? If your provider decided to do that. That would apply the face-to-face definition, right? So what do we do face-to-face? We examine the patient, we do a great deal of counseling, we give the patient instructions, we answer questions of the patient and family. All of those tasks happen face-to-face with the patient. And then the third definition is time on day, all right, the time on the date. This definition uniquely applies to the new CPT codes, the new guidelines for the established CPT codes that we've had for a while, 99202 through 99215, which reads your office or other outpatient visits. For clarity, what I teach my folks is office or other unclassified outpatient visits, because we have quite a few outpatient statuses. Observation is outpatient. The ED is outpatient. There's some other codes that are outpatient specific, but they are better classified with other codes. So 99202 to 215 is going to be for those codes that are not better classifiable somewhere else. You may also find yourself using this knowing that, so CMS years ago abandoned paying for consultations. They just said, you know what, we're no longer kind of dealing with this debacle of did the referring physician document the consultation or not, and who do we penalize for that, and all of that. They just stopped paying across the board for consultations in our outpatients. So when it comes to your outpatient consultations that are justifiably consultations, but you have Medicare or what I call a CMS referencing payer, a payer who isn't Medicare but is following Medicare's rules, like we see United Healthcare to do very timely, like more than anybody, then you would apply the rule for the office or other outpatient services. So if I would bill a 9924 1 through 5, right, 99241 1, 2, 3, 4, 5, if I would bill one of those codes but the payer doesn't pay that, I'm going to end up billing office or other outpatient consultation services most likely, right? Now I could also bill ED visits if I'm doing a consult in the ED, but let's say it's not. If it's not a better classified, then you're going to find yourself coding 99202 to 215. And the definition for 202 to 215 is time spent on the day. This is where this really became a lot easier for providers, because I think the AMA kind of heard the intention, and we're doing a lot of work that doesn't take place face to face with a patient, and we're really not, that's not being accounted for when we think about the work that kind of deals with managing that patient properly. For example, me working, one of my specialties is pain management. One of the things the pain management doctors do quite commonly is before the patient comes in, they'll review the PDMP, right? They'll review their medication use, right? And make sure what drugs they've gotten where, to make sure they're not getting controlled substances from somewhere other than that practice, right? Your provider might review records, for example. They might discuss cases with other providers, whatever the situation might be, on that date of service. These new codes use the time on day definition, meaning it no longer has to be face to face with the patient like it did before. So if there's some pre-service work, like maybe it's a new patient and you requested the records, or it's an established patient, you got records before the patient got there. Some providers like, I don't want to review these records before the patient comes in. Okay, the patient's here now, or I know the patient's coming today, I'm going to review these records. It takes you 20 minutes to review those records. And then you see the patient, and maybe it takes you 15-20 minutes when you're with the patient face to face. And by the time you put in orders, contact the other provider, whatever, set up referrals, all of those kind of tasks that you're spending on that patient that day, whether or not they're there or not, you can add up all of those periods to report a time on day service, E&M. These definitions are important because not only, once you understand that, when you exceed the amount of time based on the CPT code that you're reporting, because remember, these code set have an alternative for you to report based on time or something else. For the office visit codes, it's time or medical decision making. And of course, you'd only want to use the prolonged services we're going to talk about if you've coded based on time alone. So you have to have something else. And the other two that use unit and floor time and face-to-face, they have a metric where you could also code instead by the key components. So it's whatever works out best for you that would determine your level of service. So there's some alternative, and this is why I said doesn't count for ED because you can't code by time, but although you have key components there, and doesn't count for time-based critical care because you only code based on time. So there's no history exam kind of elements that are factors in your coding for those types of service. Now that you're clear on the 3-time definitions, that should also help you when it comes to prolonged services and know what code is appropriate for it. So when it comes to your unit and floor time is something that applies to facility settings. So you would use, if the unit and floor time definition is applicable, and it's valid, you would actually use the CPT codes 99356 to 57 when you exceed the time threshold allowable by that code. Now, again, you got to exceed it by 30 minutes for 356 and 357. That's what's required. Same is the case with 354 and 55. If you are using the face-to-face definition, you're likely dealing with that outpatient setting like a consultation or a home visit. You would end up using 99354 and 355 for your time metrics once you exceed that, because that's the face-to-face definition, right? So if you apply the face-to-face definition, you're going to use the prolonged code that goes with that. And when you're dealing with time on day, as we see in those office visit codes, you would end up using the prolonged service 99417. Now, a note to understand, CMS and the AMA didn't necessarily agree on where the thresholds were with regard to exceeding the amount of time for the base code. So CMS created a HCPCS code G2212, which is like an equivalent of 99417, the differences being where the cutoffs are. So the next minute at the end of that code range for CPT is where you can get your 99417. You've got to exceed that in order to, by 15 minutes in order to get the G2212. So you got to get to like 89 minutes before you can actually report that service. 15 minutes above the base code before you could report that service. So now that you understand the 3-time definitions, you should be able to very easily, when necessary, also report the appropriate prolonged service. A final thought with regard to the activities related to these prolonged service. It's a lot easier if you have a better code to report instead of factoring it into your time, then you would use that code. For example, we've got codes for medical conferences. We see these a lot in pediatrics with patients that have pretty complex medical conditions where multiple providers are involved. Medical conferences have very specific guidelines on what has to be met for you to report that when the patient is not present. So if your provider doesn't meet the metric, let's say it's not 3 specialties involved, right? You might very well capture that into your time on day service if you're reporting office or other outpatient, other class office or other unclassified outpatient services where you code 99202 to 215. It would be okay for you to do that because you didn't meet the metric for it. If you spent a great deal of time, however, on literature review or record review on that day, instead of you using the prolonged without direct patient contact 99358 code, instead of using that, you could factor that into your time on the day, right? But if you did the record review on another date, then you would just have the 99358 if you'd satisfied the guidelines associated with that code set. So if you found that, well, wait a second, I didn't meet the 3 provider requirement, or counting myself, I didn't have 2 other providers involved in that conference, so I didn't meet the metric for that, maybe that discussion either gets bundled into unit and floor time if it's applicable to that, or time on day if it's applicable to that. It just, you've got to find your type of service. And if it doesn't fit into that one for medical conferences, then perhaps you could have a prolonged without patient contact service. So hopefully you better understand now the definition between unit and floor time, face-to-face time, time on day, when you use them, and when your prolonged services are appropriate, and the prolonged services that you report for each of those services. So I am your friend Doris the Coder, signing out with another video. I hope you found it helpful, and you know what I say. Like it if you do, share, subscribe. Let me know what you want to hear. Let me know how I've done, and until then, I will see you in the next video.